Hello and welcome to this talk on the Integrative Developmental model of supervision. For this talk, I'm utilising this book, IDM Supervision, an Integrative Developmental Model for Supervising Counsellors and Therapists by Stoltenberg and McNeill. I have the third edition here. I will just be utilising this chapter 2. The book covers this model in far more depth, but chapter 2 provides a nice overview. So if you enjoy this video, I urge you to get a copy of the book. Let's just start with what the IDM means before we dig into any more detail. So it stands for an Integrative Developmental Model of Supervision. So it's a model of supervision for supervisors who are supervising therapists and counsellors. It's developmental because it looks at the therapist's development over time. You could think about, well, anyone in a profession, but in this case, a therapist growing from a novice, someone who's very new, to an expert, to someone who's very experienced. And they grow, they develop from novice to expert, and this model looks at that development over time and looks at how a supervisor might adapt to the therapist's development over time. And it's integrative because it is not modality specific, okay? This is not a supervision model for person-centered therapists or for cognitive therapists or for psychoanalysts. It can be applied to any modality. So therefore, we have an integrative developmental model of supervision. So let's look at chapter 2. We are looking at an overview of this model today. So this model, there are basically three aspects to it. We have levels, we have structures, and we have domains. So if you've heard anything about this model before, you've probably first heard of levels. So earlier models of psychotherapist development have suggested that growth occurs in broad stages, labelled as level 1, level 2, and so on. And in the IDM, they retain this construct of levels 1 to 3. So now we can break down novice to expert as level 1, level 2, level 3. However, most therapists tend to function at different levels across areas of mental health service delivery. For example, a supervisor may function with a relatively high degree of confidence and autonomy when conducting individual psychotherapy with a depressed female client, but due to little experience in training, may lack this confidence and autonomy when working with issues of childhood sexual abuse. So it's not as simple as labelling someone a level 1 therapist, a level 2 therapist, but they might be level 1 at offering cognitive interventions, but level 3 at offering assessments. So we might have different levels of confidence and experiences in different areas of our profession. That makes sense. And it's these areas that we're calling domains. So these researchers found that supervisees desire different types of supervision, varying in degree of structure provided by the supervisor, depending on their experience with the problems presented by particular clients. So this gives us some indication of why it's perhaps useful, practical to look at a therapist's level in a particular domain, because if I'm new to something, if I'm a novice, then I might want different supervision than if I were an expert at something. Makes sense, doesn't it? I might want more structure from my supervisor if I'm very new to giving a particular intervention, for example. Whereas if I'm an expert and I'm reflecting on myself in my practice, I probably want less structure offered by my supervisor. Therefore, supervisors need to know not only how to provide optimal supervision for different levels, but also to be able to assess the level of development across professional activities. So in order to offer different supervision depending on the level of the domain we're looking at, the supervisor obviously needs to be able to assess their supervisees, their therapists, levels across their domains. So we've looked at levels, we've briefly touched on domains, which we will dig into more detail. But firstly, let's look at what we mean by structures, overriding structures. We have found it useful to monitor trainee development by closely attending to 3 overriding structures that provide markers in assessing professional growth. So we've just highlighted, haven't we, that supervisors need to be able to assess their supervisees' levels, and they can do that by monitoring 3 structures, which, if you like, are a part of each level. So these 3 structures are self and other awareness, motivation, and autonomy. Let's look at each in turn. So the first of these 3 structures is self and other awareness. So this structure has both cognitive and affective components, affective meaning emotional. And it indicates where the individual is in terms of self-preoccupation, awareness of the client's inner world, and enlightened self-awareness. The cognitive component describes the content of the thought processes characteristic across levels, and the affective component accounts for changes in emotions, such as anxiety. So, for example, if I'm at a lower level, I'm probably going to be more self-preoccupied, which means I might be more anxious. If I'm more self-preoccupied, I'm probably able to be less aware of my client's internal world. And probably the less experienced I am, the less self-aware I am. And the more experienced I am, the less self-preoccupied I become, the more self-aware I am, and the more able I am to be attuned to my client's inner world. The trainee's ability to engage in effective empathic understanding is an important aspect of this structure. So yeah, the more experienced I am, perhaps the more I'm able to empathically attune to my clients. The content of what is in working memory during therapy, as well as the nature of the KIA. Okay, so we need to look at a couple of terms here. KIA stands for knowledge in action. Knowledge in action. You can think of this as like procedural knowledge. So for example, riding a bike, okay? It's like a muscle memory. It's something I've learned how to do. And when I'm riding a bike, that knowledge is in action because I'm doing it. If I'm very practiced and experienced at riding a bike, I don't even have to think about it. It's I can now do it on autopilot. So that's knowledge in action. RIA, R-I-A, stands for reflection in action. We use reflection in action when a problem arises or something doesn't meet our expectations. So if I'm riding a bike and my brakes don't seem to work, suddenly I'm not on autopilot anymore. I'm like, oh no, I have this problem I need to resolve. I need to reflect and think in real time, in action, and decide what to do about that. So maybe I can scan around for the nearest hill to go up so I can slow down. So the degree to which I can reflect in real time is reflection in action. So the content of what is in working memory during therapy, as well as the nature of the knowledge in action for a particular trainee, and the degree to which reflection in action can positively affect the therapy process are characteristics of different levels for this structure. So the more practiced I am, the more knowledge in action I will have across many different skills. And perhaps the more confident and practiced I am, the more able I am to reflect in real time when things happen in session that don't match my expectations? Can I think on my feet? Differences will also be apparent in the nature of the reflection on action that occurs in and outside of supervision. So reflection in action is reflecting in real time whilst the problem is happening. But if I run with my cycling example, reflection on action might be something I do later that night. I might be lying in bed thinking about riding my bike and my brake's not working, and considering, maybe I should really think about how often I maintain my bike, get it serviced. Or I might be reflecting on what I could have done instead when my brakes failed compared to what I did do. So this is reflection, but just not in real time, reflecting later. And we, as therapists, we do that, of course, in supervision, but we also do that outside of supervision, probably in our own time. So this structure reflects the development of the therapist's knowledge base, cognitive and affective, as well as the therapist's ability to utilize this knowledge in professional context. So that was self and other awareness. The second structure is motivation. This reflects the supervisee's interest, investment, and effort expended in clinical training and practice. Changes over time tend to go from early high levels through a vacillation from day to day and client to client, culminating in a stable degree of motivation. So when I'm new, when I'm a novice, I might be very motivated to learn a lot. When I've learned quite a bit, that I'm sometimes successful, I might vacillate. My motivation might swing around quite a bit. Sometimes I might want to not look into something new because I'm familiar and comfortable with what I have, so my motivation might decrease. Another day, I might suddenly feel incompetent again and get a burst of motivation to learn something new. But when I become more expert, my degree of motivation is quite stable across time. This structure is affected by the trainee's awareness of cognitive and affective components of the learning and practice environments, which can elicit a range of reactions from confusion to clarity, self-absorption to empathy, and anxiety to a sense of confidence and efficacy. Clearly, these reactions impact the trainee's sense of control and motivation, which in turn affect his or her willingness to engage in the often complex and challenging actions of learning and practice. So the more aware I am of the different reactions I have to the learning process, how does it feel to reflect on a difficult session? I might be scared to reflect, scared to look at my actions, my behavior, my choices. It might give me anxiety. Or I might reflect on something, adapt. It might go well, and I suddenly might feel confident and efficacious. So obviously how I feel and how aware I am of how I feel in regards to learning can affect my motivation and how willing I am to approach new challenges. The last structure is autonomy. These are the changes in the degree of independence demonstrated by trainees. Beginners tend to be rather dependent, and then they grow into a sort of dependency-autonomy conflict. So sometimes I want to be out on my own, sometimes I need more help. They refer to this perhaps as a professional adolescence. And then over time, as we get more experience, we become more conditionally autonomous. So we go from dependent to a sort of inner conflict of dependence and autonomy to generally autonomous and perhaps on conditions that we're happy to ask for help when we know we need it. I'm happy to consult with a colleague who's an expert in eating disorders, for example, and that doesn't threaten me to ask for that help. A desire for independence and a sense of efficacy either can have a motivating effect on learning if the trainee perceives that he or she can develop adequate skills and positively affect professional growth, or can elicit a reticence to explore new understandings and approaches for fear of incompetence or unwillingness to invest in the learning process. So our desire to be independent might motivate us to learn more if I think I can learn on my own, or it might make me want to hide away and not look at new skills or approaches because I fear I will feel incompetent again, and I don't want to feel that way again. I've only just got out of level 1, for example, so that can demotivate me. This response can also limit the trainee's investment in self-evaluation or evaluation by others, as well as critical reflection on action, so as not to confront evidence that is contrary to comfortable perceptions of competence. So if I've gone from novice and being new, being a beginner, to someone who now sometimes feels competent and does good work, that can put me off reflecting. It can put me off asking for evaluation or evaluating myself, because I don't want to revisit those feelings of being uncomfortable, of not feeling good enough, for example. You can really see here how autonomy and motivation play off each other. So we've got our levels, our 3 levels. We've got our 3 structures and how they interplay across levels. Now let's look at the third aspect of the IDM, which is domains, specific domains. It says here, we consider 8 general domains of clinical activity. So as a therapist, there might be 8 domains of things we do. Let's put it that way. These domains are overly large and inclusive, but are meant to highlight the need to attend to particular areas of practice in considering a trainee's development, rather than to broadly assume a level of professional development that lacks meaning and relevance. So they're saying that these 8 domains, they don't fully encapsulate all of what there is to be done in therapy. They're too broad for that, but they point us in directions of areas of skills and knowledge. So let's look then at these 8 specific domains. So intervention, skills, competence. How competent are we at providing skills or interventions in psychotherapy? Assessment techniques. What's my skill and knowledge about giving assessments? Interpersonal assessment. So sounds very similar to assessment techniques. Assessment techniques might be more about the knowledge about different forms you use, the questions you ask in assessment, how to do risk assessments, things like that. Whereas interpersonal assessment is about your use of self in assessment. So how do I use my internal reactions, my thoughts and feelings I have in response to my client, to the other person? How do I use my own reactions, my own internal life to make assessments? Slightly different to the more objective form filling of this type of assessment. Case conceptualization, which includes diagnosing. So this includes a therapist's understanding of how clients' characteristics, history, and life circumstances blend to affect adjustment. So in what way is this person suffering? How did they come to be suffering in this way? How do we understand this suffering? How would they like things to be different? How is it possible for things to be different? And what is the road from A to B? What does that look like? That's our case conceptualization skills. Individual differences. So this includes working with an understanding of gender, ethnicity, socioeconomic status, and cultural influences. Theoretical orientation. So this is about one's knowledge of the different theories and modalities of psychology and psychotherapy. Treatment plans and goals. So based on my case conceptualization, how do I then, with the client, perhaps plan what goals are we working at and how are we going to get there? The sequencing of issues and interventions leading to achievement of therapeutic goals. And finally, the 8th one, professional ethics, which can include how professional ethics and standards of practice intertwine with one's personal ethics. So, we've laid out then the 3 levels, the 3 structures within each of those levels, and the 8 domains of practice across which these different levels apply. Let's look then in more detail at the structures across levels of therapist development. So the IDM views development within specific domains as progressing through levels 1, 2, and 3, with a final push towards integration across these domains. So they call this final level, level 3I. I stands for integrated. So this is about how you become level 3 at many domains and how they integrate with one another. So level 1 then. What does being level 1 in a particular domain look like? Often there's limited directly relevant experience, so probably the person hasn't had much experience. Their background knowledge will usually be limited to an introduction to theories and techniques at the graduate level. Typically, a focus on relationship skills and simple intervention strategies is common, while others will initially focus heavily on assessment. Supervisees who may have had considerable experience in other domains of clinical activity nevertheless will be functioning at level 1 if these experiences are significantly different from what they're doing now. So if I've trained in cognitive therapy and I'm now training in person-centered therapy, they might be significantly different enough that I'm now at level 1, even though I'm a fairly competent cognitive therapist. New trainees will be level 1 across most or all domains. Even relatively seasoned professionals will have limited background in certain domains of clinical experience. So let's look at self and other awareness in level 1. So learning new skills, theories, strategies, and so on tends to result in considerable confusion and anxiety in level 1. One's evaluation of self-performance is often guided by a perception of their proficiency in faithfully performing a given technique or following a particular strategy. New declarative knowledge is necessary but not sufficient. Procedural knowledge, or how to best utilize and implement information, is necessary for effective practice. So it's not about reading how to ride a bike, it's about practicing and knowing how to ride a bike. This cognitive self-focus leaves little attentional capacity for considering the client's perspective, for empathy, or even for processing the therapist's own affective or cognitive reactions to the client. So my self-preoccupation with, let's say, conducting a particular intervention means I don't have enough space to also empathically put myself in the client's shoes in this moment, or even perhaps consider my own emotional reactions to what's happening in the moment. Considerable reflection in action on the adequacy of knowledge in action and reflection on action are necessary for the trainee to develop effective and efficient procedures for therapeutic skill intervention. So at level 1, I need to do a lot of reflecting on what's happening here and now, and on how adequate my muscle memory of using these skills is. And also I need to do a lot of reflecting on my actions after the fact. This self-focus tends to elicit significant anxiety, which can complicate effective performance. So needing to do so much reflection can be very anxiety-provoking and understandably, therefore, can affect our performance. Concern about being incompetent, a lack of self-efficacy, or control of the ability to be effective, or simply confusion regarding what to do can elicit an anxious response, understandably. This can stimulate or motivate a desire to learn, or it can lead to a trainee to fall back on familiar ways of interacting with people developed outside of therapy. So we might fall back onto old familiar habits, not using the therapeutic skills we've learned. Supervisors need to monitor both cognitive and affective components. So let's look at that. Cognitive components can be confusion, lack of certainty, a loss of a sense of what to do, due to a need to reflect constantly on rules and procedures, skills and theories. It's difficult for trainees to carefully listen to and process information provided by the client. It's also difficult for them to recall relevant information, to utilize it in working memory in the here and now, immediately in the session, when they are struggling to understand the client's perspective. That makes sense, right? I can do one or the other. I can sort of concentrate on the skills and theory I need to use, or I can listen carefully to my client, but it's hard to do both at the same time. It takes time. Adding facts and skills is not enough. Procedures for utilizing information from memory in a way that impacts a trainee's implementation of effective therapeutic behaviors will only improve with relevant experience, reflection, deliberate practice, and accurate feedback. So practice, practice, practice. Reflection, reflection, reflection. Add to this the trainee's concern with evaluation by the client and the supervisor. So fear of critical feedback or fear of making mistakes, and it's easy to see how confusion can reign. Sometimes this is termed analysis paralysis. I'm so self-conscious that I can't do anything. What about the affective side or the emotional side? So level 1 supervisees are characterized by a focus or a preoccupation on the self. So I'm anxiously preoccupied with myself, rather than a sort of healthy, insightful self-reflection and self-awareness. So he or she may experience anxiety, fear, sadness, and a range of other emotions that emanate from the client. So this is understandable, right? When we empathize with someone, if they're sad, we can feel some of that sadness. If they're anxious, we can feel some of that anxiety. But we may not have the self-awareness to know where that's coming from. And when we've got our own self-conscious preoccupation going on as well, mixed in with all the client's feelings, it can be overwhelming. So level 1 motivation, they're typically highly motivated. They desire to move quickly from neophyte to expert. This can be a strong motivator. Some of this early motivation is a function of wanting to grow beyond the uncertainty, confusion, and anxiety associated with this stage. So this motivation is often reflected in a desire to learn the best, correct, or favoured approach to dealing with clinical problems. Level 1 trainees are likely to function at varying levels of extrinsic motivation. So to pass certain assessments, for example. The trainee's behaviour can be seen as significantly controlled by externally provided rewards and punishments from supervisors, professors, and even clients, and compliance to training demands. As experience and proficiency increase, the level of perceived internal causality and self-control, with more internal rewards and punishments, is expected to develop. So motivation isn't just on a dimension of high or low, it's also on a dimension of extrinsic versus intrinsic, and a beginner's more likely to have extrinsic motivation to pass courses, to please clients, please supervisors, and then over time we might become more intrinsically motivated as we learn to self-assess and feel more self-control. Level 1 autonomy then. Novice clinicians show considerable dependence on the supervisor, which is an appropriate response to their lack of knowledge and experience. So they're dependent, and rightly so, essentially. They're looking to authority figures or other sources to provide information they can elaborate on and integrate into an overall structure from which to understand the clinical process and direct therapeutic behaviour. Early successes tend to decrease the supervisee's perception of the need to depend on the supervisor and lead to a desire for more autonomy in supervision and clinical practice. This ties in so nicely to attachment theory, right? That we are very dependent to start with. We cling to our secure base, and then maybe we go explore a bit, we learn something new, and we come back, and then we can explore a bit further, come back, and we gain more autonomy as we individuate and build confidence over time. A rather simplistic understanding of a complex phenomenon might lead supervisees to desire more autonomy in practice than is actually warranted. So sometimes we might get ahead of ourselves and feel like we want more autonomy than actually would be helpful right now because we've got an overly simplistic understanding of the way things work. A reticence to experience a sense of incompetence with new skills or approaches, or demands for a more complex view of the process from the supervisor, can reduce the trainee's motivation to learn. So we can actually be put off from learning a more complex view if our simplistic one is working, because we don't want to feel, again, that sense of confusion and incompetence. So the authors use a metaphor to describe this process, and it's a metaphor of rock climbing. So we're imagining the client is a novice climber who has slipped into a crevasse and is calling to the supervisee for help. And the level 1 climber or supervisee may stand at the edge of the crevasse, mountain climbing manual in hand, and yell down advice, or focus primarily on emotionally supporting the stranded climber. Alternatively, the supervisee may go off and seek guidance from the experienced team leader concerning how to assist the stranded person. In either case, the supervisee is attempting to assist the client despite having had little or no experience with or personal understanding of the process. He or she is standing on the edge, sending interventions down to the client. You feel stuck. Reach for that rock. Stretch for that handhold. That's how I've done it. You can do it. Hoping the client will find his or her way out, communicating a developing understanding of the climbing process to the stranded climber, or calming fears and seeing that this can have an impact is sometimes sufficient. The supervisee's perception of his or her understanding of rock climbing is enhanced, and he or she feels the power of therapy and begins to develop confidence. On the other hand, a lack of progress by the climber in escaping the crevasse may be discounted by the supervisee as the climber not yet being ready to climb out. So that was level 1. Let's look then at level 2. So we have the first structure, which is self and other awareness, which switches away from the primary focus on the supervisee's own thoughts and performance toward more of a focus on the client. That is the heart of this structure in level 2. So cognitively then, with a freeing up of awareness from self-preoccupation, the trainee has more attention available to direct towards the client and can more fully understand the client's world. But as the trainee attends more to the reactions of the client in therapy, the inadequacy of applying skills to clients in certain context or a one-size-fits-all approach becomes more apparent. So the knowledge in action now includes sufficiently developed fundamental counselling skills to allow the trainee to provide a safer environment for the client, which can stimulate more exploration and disclosure. So yes, the trainee has more general skills, but their awareness of the client's responses to these skills actually opens their eyes to how sometimes these are not adequate. Prior approaches perceived by the trainee to have successfully worked in the past may now prove to be inadequate, which requires more reflection in action and reflection on action that occurs between sessions and in supervision can help this process. So actually being more attending and empathic to the client can have us be more aware of when things aren't going as well, which can have us need to reflect more. So affective. The supervisee's newly developed ability to focus on the client can yield a sensing of the emotional experience of the client. Okay, so now we're more empathically attuned to the client, we might be feeling more of their feelings. The level 2 therapist can develop the ability to pick up on verbal and non-verbal cues that communicate the inner emotional experience of the client, which can add considerable depth. Can also increase the likelihood of enmeshment, countertransference, or an intervention paralysis for the supervisee, who may now be nearly as emotionally overwhelmed as is the client. So if we are attuned to others, both pleasant and unpleasant emotions are more contagious. Careful attention to the client can allow the trainee to access emotions more directly. Closely attending to another with intensive eye contact allows mirror neurons to be activated, resulting in experiencing the same emotions as the other person. So again, these emotions being contagious, and we're more aware of them now. So we've gone from being so self-preoccupied we're not as aware of the inner life of the client, to being very aware and very affected by the inner life of the client. And the transition between levels 2 and 3 involves coming slightly back out of that and holding both at the same time. I can both be attuned to you and also be able to think rationally and theoretically about how to respond. Level 2 motivation then. The confidence that accompanies perceptions of self-efficacy in clinical practice has been shaken by an increased awareness of the complexity of the enterprise. So some supervisees react to this confusion by seeking additional support and guidance, whereas others, re-acknowledging confusion and frustration, can reduce motivation. So recognizing how complex therapy is can have two potential responses that can make some people more motivated to seek help, seek guidance, and learn more, and it can put other people off. For some trainees, there ensues a questioning of their suitability to the profession. Fear of incompetence, contrasting with feelings of confidence and effectiveness, can be reflected in vacillating motivation. So sometimes I'm feeling incompetent, sometimes I'm feeling confident and effective, and my motivation adjusts relative to this. This realization that a good relationship with a client or utilizing techniques in therapy isn't always sufficient to bring about change results in the uncomfortable feeling that they aren't sufficiently accomplished as therapists. And finally, in level 2, autonomy, the dependence of level 1 has given way to a sense of efficacy and a desire for some autonomy. This often takes the shape of a dependency-autonomy conflict, such that takes place in adolescence. Sometimes confidence will be high, and the supervisee will want to assertively develop his own ideas. At other times, the trainee experiences a lack of control or sense of incompetence and becomes dependent or even evasive. So back to our metaphor then. Now the mountain climber has moved from standing on the edge of the crevasse and sending down observations or instructions to climbing down into the hole with the stranded climber. The stranded climber now feels more understood, realizing that the supervisee can better see the problem from his or her perspective. The new challenge is for someone to figure a way out. The supervisee may become as stranded and fearful as the client. They both may now be crying up to the supervisor to help them out, or giving up on the possibility of rescue. Occasionally, the client will take the lead in climbing out of the crevasse. I like this metaphor. So from level 1, we're shouting down instructions. Level 2, we've jumped into the crevasse with the client or stranded climber. And now we move to level 3. So let's look at the structures in self and other awareness of level 3. Some of the focus on the self we saw in level 1 returns, but rather than self-preoccupation, the level 3 therapist exhibits more insightful self-awareness. Therapist is able to alternate in intensive focus on the client and working to understand the client's world with the ability to activate and move into working memory relevant schemata regarding client processes and characteristics, as well as knowledge of relevant information and productions related to the process of therapy. So I can nicely shuttle between empathizing, putting myself in my client's shoes, and coming back to theory and knowledge and responding, empathizing with the client again, how they react to my responses, and that process becomes more fluid. Knowledge in action is more adequate to handle a broader array of practice events, and the therapist's abilities in reflection in action allow for more effective changes in strategies to occur on the fly. More challenging events, alternatives for action, and integration of knowledge across contexts will be the focus of reflection on action. So reflecting outside of session in supervision will be focused on much more difficult things now, more difficult challenges. The supervisee is more accepting of him or herself and now able to focus intensively on the client using low road processing and tapping into the emotional experience of the client, then pull back up and engage in high road processing, then more selectively labeling the emotions he or she is experiencing and conveying that back to the client. So I tap into your experience, I experience it myself, I'm able to name, talk about, label those experiences and give that back to you. The competence and confidence that have developed enable the therapist to be better able to use himself or herself, genuineness, congruence in sessions. So motivation then. Motivation is more stable and high. It's moved from extrinsic to intrinsic. The therapist's behaviour is more self-determined. There's a movement to greater congruence, awareness, and synthesis with the self. And autonomy. The therapist's commitment to retaining responsibility for his or her clinical work is characteristic. While there's a solid sense of when consultation is necessary, the therapist's firm belief in his or her autonomy and professional judgment is not easily shaken anymore. The therapist is less easily influenced by others and evaluates input from others to determine whether it passes the "it makes sense from my framework" test. There's less of a difference in levels of expertise between the supervisor and supervisee. And our metaphor then, our mountain climbing guide in level 3 is able to lower him or herself down into the crevasse, effectively communicate to the stranded climber his or her understanding of the emotional, cognitive and conceptual aspects of the problem. With calm and confidence, our supervisee assists the stranded climber in developing a plan to climb out, examining options and working from experience, as well as a detailed understanding of the client's strengths and weaknesses. While success is not guaranteed, the likelihood of both climbers rising out of the crevasse is considerably increased. Finally then, we have this level 3I, this level 3 integrative level. So let's look at that. Once the therapist has reached level 3 in a number of domains, the primary goal becomes integrating across the domains, or generalizing knowledge and skills from one domain to others, and increasing the fluidity. So integrating knowledge across domains, generalizing knowledge and skills from one domain to another. The therapist now learns to move smoothly, for example, from assessment through conceptualization, through developing treatment goals and implementing interventions. This all becomes one fluid motion. So in self and other awareness, it's characterized by a personalized understanding of clinical practice that spans the domains. The therapist is able to monitor the impact of personal life changes on professional identity and performance. So if I'm going through personal issues myself, I'm more able to monitor and assess the impact of that on my work. Motivation. It's relatively high and stable and intrinsic, and that's evident across domains. So across intervention, across assessment, across case conceptualization, across intervention, across working with difference. And finally, autonomy. The therapist is able to move conceptually and behaviourally from one domain to another with a high degree of fluidity, Professional identity is solid across most domains. And lastly, this metaphor. We can extend our metaphor for the level 3 I guide to an ability to handle most types of emergencies and challenges confronted by his or her charges on the mountain. Also, with additional training and experience, this individual may be particularly adept at training other guides to provide similar assistance to climbers who are attempting to scale everything from rocks to glaciers to mountain summits. So now this person is able to transfer knowledge and skills from one situation to another to expertly guide and help other guides across situations. Let's look at this table then. So we've got the levels down the sides and the structures across the top. So we've got motivation going from motivated to fluctuating to stable, autonomy going from dependent to ambivalent to mainly autonomous to autonomous. And we've got self and other awareness going from preoccupied and anxious to client focused and empathic to balancing empathy and self-awareness, and to that being then personalized across all domains and potentially across the lifespan and life events, knowing how, relationship changes, illnesses, etc. in one's personal life affects one's working life. Finally then, let's look at the interaction of these structures across the domains. So supervisees are typically functioning at different levels of development for various domains at a given point in time. Yeah, that's important. Right from the start, we've said that, haven't we? So the level 1 therapist has skills to learn and needs opportunities to practice. In the intervention domain, the level 1 therapist tends to focus on how the skills should be performed and when to use them. The therapist's evaluation of his or her effectiveness will be based primarily on self-perceptions of the adequacy of performing the techniques. Little awareness exists as to the efforts of these interventions on the client. So it's about getting the intervention correct, not necessarily noticing the effect it has. There is a strong desire to emulate experienced therapists, often the supervisor, as a means of developing skill and confidence. Theoretical orientation that beginners adopt is often directly tied into the perceived orientation of a role model. So I like what you do, what do you do? Often the more easily understood or unambiguous models are those to which therapists are initially drawn. Producing a comprehensive or even marginally inclusive case conceptualization or diagnosis of a client is quite difficult for beginners, so they're reliant on supervisors to help them with this, perhaps. The level 2 therapist, we can expect to see considerable increase in the therapist's sensitivity to individual differences across clients. So remember that domain of individual differences, that might come into play more now that we've, learnt interventions, assessments, case formulations. The increased empathic focus on the client allows the therapist to experience greater depth of emotional and cognitive understanding of the client, which increases the therapist's appreciation for the client's personality, experiences, and life circumstances. This greater depth and breadth of understanding of the client's world can be quite useful to the trainee in developing more adequate case conceptualizations. So more empathy can give more sensitivity to individual difference and can help with case conceptualization. On the other hand, this wealth of information, with all of its idiosyncratic nuances, can present real problems for the therapist in wading through the data and reducing the information down to a concise conceptualization. So building too much information can also inhibit and make more difficult conceptualizing a case in a more concise way. This flood of information may also cause the therapist to freeze up in terms of making any clinical decisions, that analysis paralysis. Indeed, in terms of specific therapist behaviours and client progress, a level 2 therapist may sometimes be less effective than our naively confident late level 1 therapist. So the more we know, the more paralyzed we might become, and for a period that might make us less effective. Regular reminders of professional ethics are important for level 2 therapists. The dependency-autonomy conflict can create tension in a supervisory relationship that may limit the willingness of the therapist to share feelings and thoughts with the supervisor. Becoming too enmeshed with a client or assuming too much responsibility for the client's well-being can result in unfortunate consequences. So ethics might play more of a role the more that this dependence autonomy conflict leads a therapist to want to hide things from their supervisor, do their own thing, not be watched so much. The level 3 therapist then is more able to use insightful self-awareness and awareness of the client's experience, which gives a breadth and depth of perspective. Treatment goals and plans reflect this integration of different sources of information. Knowledge of one or more guiding theories, conceptualization of the client's difficulties, and confidence in one's own abilities results in more adequate treatment plans. The level 3 therapist is able to offer more skillful assessments, monitoring his or her own responses in the clinical situation, and separating the process in order to make more objective third-person observations. This results in an improved ability to plan and carry out effective treatments. And finally, level 3I. The level 3I is not often fully achieved, but clinicians who reach this point are considered experts by their colleagues. Development within each domain is utilized to generate new awareness through integration and linking of schemata, as well as learning in response to input from others. The ongoing work of this therapist is to re-establish networks of knowledge with self-understanding that change as the individual continues to mature. So, that is a brief-ish, I don't know how brief it was, overview of the IDM, the Integrative Developmental Model of Supervision. So in summary then, it's integrative because it spans modalities. It's developmental because we're looking at how a therapist develops from novice to expert. There are 3 key aspects to the theory. The idea of levels, that there are different levels or stages we attain as we move from novice to expert. In this case, there are 4 if you count level 3I. Within those levels are different structures which enable us to monitor and evaluate those levels. So there's how aware we are of ourselves and others, both cognitively and emotionally. There's our level of motivation and our level of autonomy. And these 3 structures, which span the 3 or 4 levels, can be evaluated across different domains of practice. So assessment, case conceptualization, knowledge of theory, interventions, client differences, treatment plans. So we can look at a therapist's level across their different domains of practice and tailor supervision accordingly to what this individual might need. So, thank you for watching. Hope that was helpful. If you're interested in this, highly recommend buying the book. Take care.